Thank you very much for the introduction. So it's a great chance to speak to you all about something I think is really challenging to all of us. So we're going to talk about the following areas as our objectives. So we're going to cover the imaging options for investigating suspected postoperative complications, the normal appearances after surgery and when to suspect a complication, and then the radiological appearances of postoperative complications and their interventional management. Now, unfortunately, in the interest of time, I could probably spend all day talking about this, but I think we've got to prioritise certain areas. And what I'm going to concentrate on is postoperative CT. Fluoroscopy and ultrasound are really important in managing postoperative patients, but I just want to talk about how we're going to optimise our CT scans, because CT is probably the main workhorse that we use. How to differentiate normal from abnormal on a CT scan in the postoperative period. How to recognise what surgeons leave behind by accident, and the top things that go wrong and what they look like. And first of all, we're going to talk about postoperative CT protocolling. Now, really, the key thing, I think, is that postoperative CT is very difficult, and you have to make it as easy for yourself as you can. So use your best scanner. Don't use the old single-slice scanner or the four-slice. You need the all-singing, all-dancing 64 or 128. And give contrast if you can, because that just makes differentiation of normal from abnormal much easier, as Mike has already shown us. And most importantly, get as much information as you can before you do the scan at all. Now, my inspiration for postoperative imaging is this guy, Dr. House. The reason why I think Dr. House is such a great guy is because he asks lots of good questions. And you may not know, but the inspiration for House is Sherlock Holmes. House, Holmes, similar sort of origin. But Sherlock Holmes always hunts for the truth, and he only eliminates a possibility or a diagnosis when it's logically proved impossible. So he keeps an open mind. And being open-minded is another really key attribute for postoperative imaging. Now, another thing I like about House is that he's very straight-talking, and he often says everybody lies, and that's no more true than in postoperative imaging. We often do not get the whole truth from the people that are referring us cases. And the things that we often get misinformed about are the wrong operation, the wrong post-operative time period. People will say they're 1 day post-op, they're 1 week post-op, and also the wrong clinical status of a patient. So they'll say that they're bleeding or septic, and they've actually got a slightly wrong interpretation of what's wrong with the patient. This is a classic thing that happens from time to time. You get told about a patient that is severely, profoundly septic, and they come down and they're sat in a wheelchair chatting to you, and they're not the way that they've been sold to you, which is what you imagine, perhaps with tubes coming out of all orifices. So how do we cope with this? Well, you have to use your powers of deduction, trust your eyes, and trust your knowledge. Particularly now that you understand all of these different areas of surgery that can be done in abdominal surgery, and ask the right questions. So the questions that I always ask to start with are, what operation did you do? What is your primary clinical diagnosis? What are you actually worried about with this patient? And how long ago did you operate? These are really essential. Now, when they say what kind of operation, you need to clarify, particularly if they use one of these named operations, because sometimes they'll use the wrong name, or they'll use a name when they actually did something slightly different from the standard procedure, particularly things like Hartmann's procedure. They may have actually done an anterior section where they joined the bowel together rather than giving the patient a stoma, for example. And in this situation, Napoleon had a good phrase: a good sketch is better than a long speech, particularly where the patient's had a really complex operation. Get the surgeon down and ask them to draw exactly what they did. And this is the reason why, because there's a huge amount of nuance in abdominal surgery. So the difference between a 2-stage and a 3-stage operation, you might vary how far up the thorax that you scan, And there are a multitude of pancreatic operations, and really you do need a sketch, unless you are a real genuine expert in postoperative imaging, to actually know what on earth is going on. Now, the reason why we need these sketches is because we need to know where the anastomosis is. We need to have an idea of what specific operation-related complications there might be. For example, in the pelvis, the patient might have had a ureteric injury. Have they made any modifications to the standard technique? And were there any particular difficulties during the operation, such as division of adhesions, or bleeding, or actually accidentally entering the bowel, causing an enterotomy? So once we have all this information, I want to know what is the key clinical concern. Are you worried that the patient is bleeding? Are you worried whether the patient's obstructed or has an ileus? Has the patient perhaps got a leak or is septic? Or are they just not sure what's going on and they really don't know why, and they want a scan to try and work out why the patient's not recovering normally? And I use these categories to actually help me decide on which protocol to use. So the first protocol is a bleeding scan. This is an emergency scan. We do not have time to give the patient oral preparation, and the patient shouldn't have it because we're worried that the patient is actually bleeding. What we usually use is intravenous contrast injected quite fast, but beforehand to do a pre-contrast scan. The reason, so we're looking for these perhaps retained foreign bodies or things like that that we're not sure about, or to look for a hematoma. And then we'll use an arterial and a portal venous phase to look for contrast extravasation. Here's an example where we can see that a patient who's had bladder surgery, we can see contrast extravasation from the abdominal wall from an active bleeding point. If we move on from bleeding now to obstruction and ileus, we don't need positive oral contrast in these cases usually because the patient's bowel is dilated. The surgeons usually know that the bowel's dilated because the abdomen is very distended, or they've got an abdominal film that shows dilated bowel loops. And also, if you were the patient, you do not want to drink 1 litre of contrast when you're feeling nauseated already. Again, what we tend to do is just to give IV contrast in these patients routinely, and we image in the portal venous phase. We're going to go through some pictures of this in a few minutes. Now, in terms of sepsis or leak, I want to really concentrate on this and to get you to try and remember Route 8, slightly unusual. Route 8 is in a very nice part of France in the south. It connects Aix-en-Provence to Cannes. And the reason why I want you to remember this is because I want you to think about your route of contrast administration and to use 8% contrast. So Route 8, what route and 8% contrast. So how much contrast should you give and what kind of delay should you give should you image after your contrast? It's really important that you fill your patient up properly with contrast if you're querying a leak on CT, okay? And how much contrast and the delay we're going to go through, and it's quite logical, really. You want to test the anastomosis. That is the key. And we're going to use common sense about how much timing and how much contrast to give. So for the esophagus and stomach, these patients can just prep in the department. You can get them down for half an hour, give them maybe 500 mils of this 8% contrast, and then do the scan. And that will test the esophagus and stomach anastomosis. If we're talking about the small bowel, a proximal small bowel anastomosis, we need to give it a little bit longer and perhaps give the patient a little bit more contrast. So in this situation, we're going to maybe give them a litre and leave 60 minutes. So maybe prep these patients on the ward. But if we're looking more distally, maybe at the left colon or a distal small bowel anastomosis, we really want to give the patient a long delay, so 2 hours. If it's longer than 2 hours, that's just fine. And we can see here, this is a patient who's had a 2-hour delay, and we can see that they've got a leak from their anastomosis after a right hemicolectomy. Here's a patient that had pancreatic necrosectomy after acute pancreatitis, and the surgeon was not happy with the patient. They were septic. We gave the patient a 2-hour delay, and we can see the contrast here that's leaking from the transverse colon out into this big collection. So this isn't just necrotic pancreatic tissue, this is actually a colonic leak. So this patient had to go back to theatre to be defunctioned and have that abscess removed. When it comes to the rectum, you cannot really prep a patient's rectum from the oral end. You have to actually give rectal contrast. And again, 8% contrast. We tend to use about 500 mils, and how we actually deliver this is through a thin Foley catheter. Don't blow up the balloon, just put the catheter in the anal canal, and then use a bag and gravity just to let the contrast flow in across the anastomosis. So why do we bother giving rectal contrast? A lot of cross-sectional radiologists do not want to approach the rectum. That's one of the reasons why they gave up contrast studies. But in this situation, it's really important. So here's a case, patient with Crohn's disease who had a sigmoid colectomy. And looking at the CT scan, I can't really see very much going on that. We can see a surgical drain down in the pelvis. The patient's got a hand-sewn anastomosis, so we can't actually see where the anastomosis is. Unfortunately, after that scan that was reported as normal, the patient wasn't doing any better. They were still septic, taking a long time to recover. So this time, we gave the patient rectal contrast. And we can see really nice distension of the rectum, but now we can see that contrast has leaked outside the rectal lumen. We can also see contrast heading up along the surgical drain. And there we can see the contrast again. So the reason why you want to give rectal contrast is because it converts an impossible diagnosis into actually quite a straightforward diagnosis. And the only way to do that is actually to give the contrast rectally. The final group is the patient that the surgeon comes down and says, there's something not right with this patient. I really am not sure what's going on. These ones, again, I would give IV contrast to routinely. We'd want to give positive contrast, or you could sometimes give water, depending on what you think is going on. And then, again, rectal contrast if the patient's had pelvic surgery. So here's an example of a case. The patient's not right, they weren't really sure what's going on. This patient had ovarian surgery and debulking for cancer, and the patient had a laceration to their spleen that was undetected clinically at the time of operation. We can see active bleeding in this situation. This is just on a portal venous phase because the surgeons were not anticipating this complication. And here's another patient with poor urine output. We can see a reasonably well-distended bladder. I'm not showing you the hydronephrotic kidneys, but the reason why is because the catheter is inflated in the urethra. So deflate the balloon, put it in the bladder, patient's urine output miraculously returns to normal. So now we're going to talk a little bit about how to differentiate normal from abnormal in the post-surgical patient. And the things we're going to concentrate on are gas, fluid, and bowel distension. Now, in terms of gas, the important things to realise is that if a patient has laparoscopic surgery, they use carbon dioxide to insufflate the abdomen, and this is usually very rapidly reabsorbed. Usually everything is reabsorbed within about 2 days. So here's an example, a patient day 3 after a right hemicolectomy. There should not be any gas. There is far too much gas in this abdomen. There's also some fluid. I'm worried that there is a leak. However, with open surgery, air is introduced into the abdomen. There's a lot of nitrogen in the air. This is very slowly reabsorbed. It can often take up to 10 days, sometimes longer than that. So it's not always that straightforward in these patients to work out what is normal from abnormal, particularly if there's a small volume of gas and the patient is quite a long time post-op. And it's particularly difficult if you're not testing the anastomosis for a leak with positive contrast. So again, to make life easier for yourself, if you think that there might be a perforation, use positive contrast. And you must remember this as well. It's very, very difficult for a surgeon to go back into an abdomen after day 7 because adhesions really start to form quite extensively after day 7. Before that, there's usually a window for a surgeon to go back in and check things out. So it's where we have to really prioritise these patients. And if the surgeons aren't happy, get them down soon rather than waiting on the ward for a few days for their CT scan. Here's an example, a patient day 10 after a gastrectomy. I'm not sure what's happened there. Oh, there we go. Day 10 post-gastrectomy. There's some gas here. What's going on? I'm not really very sure. This is a duodenal stump blowout with a leak. It's very difficult to diagnose, even on CT, but particularly on a contrast study. But what we're looking for is this abnormal pattern of gas. There's too much gas here for day 10. Now, if we have gas and we're not sure really what's going on, and you've not given the patient positive contrast, you always have the option of give them the contrast, send them back to the ward, and get them back again later in the day to repeat the scan to look for contrast leak. Another option is to scan the patient the next day and see whether the gas is increasing, particularly if the surgeons really aren't sure what's going on and they just want to watch the patient. The other option is if you see gas and you think there's too much and the surgeon's really not happy with the patient, they can take them back to theatre, particularly if it's before day 7. And then the other option is to offer to aspirate any fluid to see whether actually it's bowel content. That's another option that can help in some patients to work out what's going on. Now, fluid. Fluid is very difficult sometimes, particularly in patients who've got comorbidities like heart failure or portal hypertension. Remember that the amount of fluid that you would expect to see will change depending on what has actually happened to the patient during their operation. If they have a hernia repair, they should not have fluid in the abdomen, but if they've had a really complex, protracted operation with lots of adhesions divided, then you might expect to see more fluid. And also, you're probably going to expect to see fluid in a patient that's had an acute operation who's very unwell compared to a patient who's had an elective operation. So it really depends on the patient's status and history how much you might expect to see. There are some warning signs, though. Think about whether or not you expect to see any fluid at all. So here we've got a patient who's had a laparoscopic hernia repair. There should not be any fluid in the abdomen in this kind of patient. We can see the rivets to keep the mesh in place, and we've got this abnormal fluid around. Okay, there should not be fluid. This is a patient that had a colonic injury that wasn't detected at the time of surgery. Another clue when you're looking at the fluid is to look for peritoneal enhancement. If you see abnormal peritoneal enhancement like this, this tells you that this is not just ordinary fluid, this is almost certainly infected fluid. And also, certainly you wouldn't expect to see this volume of fluid in a normal patient. So this patient has peritonitis based on the CT scan. Another thing to look for about the fluid is to look for mixed density and for flecks of gas within it, because if you look for this difference in attenuation, it can either indicate a hematoma, but also potentially an abscess. So you're looking for this difference rather than just being simple fluid. These sort of complex features make you think this is an abscess. Again, if you're not sure, offer to aspirate. Here's a small collection just under the left lobe of the liver in a patient who had a partial gastrectomy. We couldn't opacify this bit with contrast, so we offered to pop a drain in, and out came pus. Next, abdominal distension. How do we differentiate what's normal from abnormal? Well, the key thing that we need to work out is the patient obstructed or is it an ileus? Generally speaking, with obstruction, we're looking for a transition point. In ileus, we're looking for generalized dilatation of the small bowel or the large bowel. But there are a couple of tips, because cases aren't always as straightforward as this one, where there are adhesions. Remember that if you have colonic distension, a transition point, particularly around the splenic flexure, does not mean that the patient's obstructed. You often get compression of the splenic flexure. This is just an ileus. Also, ileus can sometimes just affect the large bowel or just affect the small bowel, so don't misinterpret that necessarily for obstruction. Another very important area is to watch out for the mesenteries. If you have a patient in the early postoperative period who has dilatation and it looks like a closed loop obstruction, look for the mesenteries because this can indicate ischemia of the bowel loop. And also, you look for the double transition point. Generally speaking, you'll have collapse of the proximal bowel and then collapse of the distal bowel and the transition point here, but also look for these changes in the mesentery again. This patient needs to go straight back to theatre. They can't wait, as an ordinary small bowel obstruction might. So, how to recognise what surgeons leave behind by accident. These are never events. This should never happen, but it does happen sometimes, but they are rare. So look for the high-density marker that is in a surgical swab. This is not an anastomotic leak. This is not infected embolization coils. These are the markers related to a surgical swab. Often, these swabs can look very heterogeneous in the early stages after they've been placed. So again, you can see gas and fluid around it. But after, in a delayed phase, we can see that all you have left behind is the marker. You can't actually see the swab itself. So use MPRs, again, not to mistake this for anastomotic suture lines. And remember this case earlier? This is a swab that the surgeons left in deliberately because there was bleeding during the operation. They packed the pelvis, and this is just some bleeding because the packing was inadequate. So what are the top things that go wrong and what do they look like? We've just covered it. So the conclusion is post-operative CT is difficult. You need to hunt for the truth. Everybody lies. They don't do it deliberately, but they do lie sometimes. Get on the phone to your surgeon if you're not sure what's going on, particularly before you do the scan. Ask for a sketch, particularly if the operation is difficult. Make life easier for yourself by giving the right contrast. And remember, auto route 8, choose the correct route, use 8% contrast. Remember, sometimes surgeons will leave things behind by accident. It's our job to spot them because they do not realise that there's something left behind. And surgeons need us and we need surgeons. So pick up the phone because they are actually our friends and help them out. Thank you.